AIOC for giving me this opportunity. So next few minutes I'll speak on the individualization and personalizing injections in the eye, the next big revolution in medical retina. So I don't have any financial disclosure to make. So retinal disease is a leading cause of severe vision loss. That is all we know. So I'm not going to the details of statistics. So we have a number of anti-VEGF injections as well as steroids and number of delivery systems in our armamentarium to treat the different type of retinal conditions. So all these the anti-VEGF, though they are in the anti-VEGF, they have different pharmacokinetics and pharmacodynamics as well as there are different responses of treatment we see, and that is why we will have to select which anti-VEGF to be given for which patient, and we often see some kind of misuse of this anti-VEGFs in certain situations. So anti-VEGF therapy, though it is claimed to be quite promising in different studies, but in real world scenario we see not that kind of outcome because of delay in diagnosis and progressive courses and some unpredictability of recurrence and long-term management needed for these type of cases. So how to improve outcomes? The solution is the individualization and personalization of the treatment. So how to individualize then? Number one, your clinical experience. Number two, innovative diagnostic modalities and their correlation. And number three is the deep learning. So innovative diagnostic modalities, the biomarkers, a number of biomarkers have been designed in terms of OCT, as well as angiography, as well as systemic biomarkers to define and quantify disease severity and guide treatment decisions. And these are very, very important while deciding for treatment with anti-VEGF. ARDS2 has shown the sensitivity and specificity of OCT biomarkers. So OCTA allows non-invasive high-resolution imaging of retinal and choroidal vascular cell. It is highly reproducible as well as a very simple procedure if it is available in your setup. So this is just a simple case of hemorrhagic PED. You can see there is a is there a pointer? You can see a lacy pattern of neovascularization here. Yeah. Lacy pattern of neovascularization here, and this is a post-treatment finding. You can see the change in the neovascularization membrane. So this is how this is how OCTA helps in follow-up of the cases also. Thank you. So this is another case. You can see the primary physician treating it as a CSR case, and when an angio-OCT was done, you can see a lacy pattern of the CNBM here, and it was treated with 3 doses of anti-VEGF, and you can see the change in the pattern of the neovascularization as a resolution of the fluid. So imaging biomarkers, what it? They help in subclinical diagnosis. So many of the cases, clinically, we see very less number of findings, but while you're going through the biomarkers, we can diagnose the cases. Often it does not, but correlated BCVG also, and this suggests a multitude of different disease origins. So what is an ideal treatment regimen? Maximum and maintain visual acuity benefits. Decide when to treat rather than whether to treat now. So on every visit we should plan for the next treatment protocol and titrate the treatment intervals to match patient's needs. So while comparing the treat and extend protocol with VRN protocol, you can see that multiple studies has proved that treat and extend is a superior treatment protocol in terms of this CNBM and diabetic maculopathy also. So treat and extend is a proactive and more personalized approach to reduction in associated treatment burden and better utilization of resources. But it may be sometimes difficult for high patient load situations like in India. So there are while there are cases of some optimum responders, there are some poor or non-responders also. Then what is the cause of this poor or non-response? Most important cause is a suboptimal dosing. Disease already at an advanced stage. There are multiple cellular mechanisms in lesion types and genetic variations, as Dr. Pila has mentioned, and potential tachyphylaxis also is a factor, and poor access to clinical or delayed appointment in our situation. Now this is the non-clinical condition. And how to maximize the outcome? Re-evaluation of diagnosis, if necessary, switch to alternative therapies. So we'll have to know when and how to switch to alternative therapies. So there are certain cases we can discuss in the next half. So I'll just quickly go through the cases. This is a case of IPCV. If you see, there is a nice hemorrhagic PED and this aneurysm here, and so this was treated with anti-VEGF, aflibercept, and ultimately the membrane was regressed, but the PED was persistent, and this polyp was also there. So ultimately, a focal laser was done to the polyp, and you can see the difference, the resolution of the PED here after the focal laser. So this you can see the difference of the polyp after the focal laser. So many a times we just keep on giving injections, but sometimes we need to switch up to other alternative treatment also. So this is another case. You can see this is a CNVM here, subretinal. So ranibizumab was given to the patient, but it was progressing. You can see after first injection it was progressing, second injection it was also progressing, and after third injection you can see the changes here. So at this point we changed the anti-VEGF to aflibercept, and after aflibercept you can see 3 doses of aflibercept, you can see there is a resolution of the membrane. So, but whether at this point did aflibercept work? So this is again a question. So after 2 months again the patient came with again the recurrence of the PED with SRF, and again aflibercept was given, but along with PDT, and ultimately you can see the membrane was gone. So we should know how to switch off and how to aid other treatment. So this is a young diabetic lady with you can see lots of hard exudates at the macula, sudden deterioration of vision with hemorrhage at the macula. So it was at the last trimester of pregnancy, so we cannot go for anti-VEGF theoretically. So we decided to go for PRP as well as dexamethasone implant. So you can see after a single dexamethasone implant, there is a resolution of, along with PRP, there is a resolution of the retinal findings. And ultimately, after the delivery, we switch up to anti-VEGF, and after 2 years of follow-up, you can see the retina was quite good looking, but there was the development of cataract in the eye, and so cataract surgery was done, and this is the whole scenario of the patient, you can see. This is not moving slides.
Okay, Manab, I think the point well made.
Yeah.
A lot of biomarkers,
Yeah.
and the newer, AI is a very new thing which you are going to speak about, I know,
That
because deep learning gets you a lot of information as to how each person may respond, right?
Yeah, so the three components of the artificial intelligence, like artificial intelligence, machine learning, and deep learning. So we should know the because these are the new things to be added to our treatment protocols in recent years.
Yeah.
So thank you very much.
Yeah. Thank you very much for providing us with an overview of personalized